Good morning, everybody. Welcome. Happy Friday and Happy New Year and upcoming Year of the Dragon. I'm very happy to introduce Dr. Cimino, Dr. Jim Cimino, for our initial talk of the new year and also of our new department of Biomedical Informatics and Data Science. Dr. Cimino needs no introduction for many of us. He's a distinguished professor of medicine and chair of the new DBIDS department at UAB. And he's internal medicine. He's leader in the field, has many awards that he usually just waves them away because there's so many and they take too long. Previously at Columbia, had fellowship at Mass General and Harvard, and also previously at the NIH, doing where he introduced many tools to help improve research there. And he's going to present his annual, much anticipated event, the fun, entertaining Biomedical and Health Informatics Year in Review. Dr. Cimino.
Okay, thank you. Thank you. And that was Amy Wong, faculty in medicine, but soon to be biomedical informatics and data science when I can get all the paperwork done. So the department's brand new. I'll talk a little bit about it at the end, but it's so we're still in transition. So this, as Amy mentioned, is a talk from the AMIA Fall Symposium that I've given for the last 5 or 6 years. And it's a very brief tour of the year's influential papers selected by working groups in the American Medical Informatics Association. So let me just jump in. No relevant relationships or commercial interests that I know of. So after participating in the session, you should have a pretty good sense of the scope of informatics research, biomedical informatics research. Think about if you're joining AMIA, which working groups might be of interest to you, and be inspired to publish significant work. So next year, your paper will be included in this publication. So the process, very briefly, the AMIA working groups are asked to nominate papers. And then I had this work with the AMIA student working group to get trainees, medical students, undergrad students, postdocs to help me pick interesting ones. And then they got audiovisual materials were available from authors, and they made the slides, and I edited the slides. And then we did a presentation together. So the talk is a guided tour of the papers and slides. It's not, you're not going to go away having learned in depth some new information about biomedical informatics. What you will learn is the kinds of things people are working on, and then you can go to the original papers and learn about those more. And I'll just hopefully pique your interest in some of those. And then I'll try to make some sense of it all. So these are my trainees, and you know, they were fantastic. It was really great working with them, but I realized just now that not only am I giving somebody else's talk, I'm giving 20 people's talk. So I didn't actually present any of these except the final slide. So let's see how I do presenting other people's slides. So just so you're oriented, the way my slides look, I'll have the title of the journal and the journal. I'll have the first and the senior authors and some institution, and then some summary points about the paper, what it's about. And then on other slides that have interesting observations, audiovisual and other things. And sometimes we'll do an honorable mention for one of the working group areas. So we'll start with education. As you can imagine, that, you know, these papers went from September, or I guess October 1, 2022 to September 30, 2023. So there was good representation of large language models, generative AI, that sort of thing. And I expect next year, if they ask me to do this again, it'll be even more. So ChatGPT and the clinical informatics board examination. So that clinical informatics is a thing that you get a subspecialty in biomedical and clinical informatics if you are already specialized in something like surgery, internal medicine. And so they wanted to look and see could ChatGPT pass the test, and it was Joachim McChrystal, Chris Lehman, and others at Vanderbilt University. So they assessed its ability to pass this board exam, which used to be easy. It's getting harder and harder every year, but reasonably easy if you've gone through a training program. 260 multiple choice questions. They excluded those that used visual media because they weren't using a version that could handle that. And they found the freely available version of ChatGPT performed well and probably could pass the exam. And then here they broke it down into different categories, and you can see, you know, you got a C. And you know what's interesting is that 30 years ago, Ida Berner, the late Ida Berner, just passed away, wrote a paper in the New England Journal of Medicine on how you evaluate systems like this, how you evaluate expert systems. And it was really groundbreaking at the time because people were building these things, including me, and we had no idea. We said, gee, it got the right answer. No, it didn't get the right answer. Well, what's the right answer? If it's suggesting good things, you know, maybe the next patient will have that. So how do you figure that out? And she figured out how to do that 30 years ago. So it was an interesting study. But what they thought about was how, not about, oh, somebody's going to use ChatGPT to cheat on an exam. This exam is done in person, but I do questions online now through the Board of Internal Medicine, and I'm allowed to use any source I want except another human being. So I could, if I was silly, use ChatGPT to try to answer medical questions and see if I could pass the exam. But I think the insight is that we're going to start thinking about how to shift how we learn. And ChatGPT and these other things aren't cheats. They're going to be tools that we're going to use to help us. So that just like I go into Access Medicine and type in, oh, I think this patient has this disease. Let me see what it says. And I read and go, yeah, he has this disease. Now, what's the treatment? I can't remember. Well, I'm in practice. I don't try to remember what the latest treatment is for everything. I go look it up. I don't want to make a mistake. So I think we use these things just as easily. I had to write a letter yesterday and I couldn't remember somebody's name who was here a bunch of years ago. And I'm terrible with names. I'll meet you tomorrow and I won't remember your name. It's a weird problem. But I just said, well, who's this person? And it told me who it was. It was amazing. Now, if it was yesterday, they wouldn't have known because it goes back to 2022, but it was about 5-6 years ago. It worked great. All right. So maybe in the future, we will be testing how people use these resources in the process of answering questions so that they, for instance, aren't mistaken, not led astray by hallucinations or confabulation. In the education category, we also had recommendations from International Medical Informatics Association on education in biomedical and health science. And they put out a bunch of recommendations and they compared 8 frameworks that had been previously published. And I won't go into all these, but you can see all these different frameworks from all around the world and what the different things they stress, and they compared and contrasted those. And if you want the details, you can go to the paper. And I will have QR codes at the end. I'll have a link for the slides and so and all the citations. So you don't have to write anything down, at least not yet. Okay. Also in education, they gave us a bunch of good papers. So training digital natives to transform healthcare, a 5-tiered approach for integrating clinical informatics into undergraduate medical education. So I learned 2 things just from the title. I didn't know what a digital native was, so I looked that up. That's somebody who's grown up in the sort of connected internet-based, network-based world, like probably all of you, and definitely not me. And also that when you're a PhD student, you're called a graduate. When you're a medical student, you're called an undergraduate. So anyway, it was about introducing clinical informatics into medical school curriculum. So for instance, UAB, as far as I know, no clinical informatics in the UAB medical. Is that right, Bob? We don't have that. We tried it at Columbia. It was a dismal failure because those digital natives didn't want to know anything about what we were trying to teach them about informatics. However, there are, at University of Pennsylvania, they have successfully developed a number of different programs that are introduced at different points in the curriculum. So worth looking at. Okay, so this is what we're going to do. I'm going to go whiz through these papers. I'll stop and talk about some of the ones that are interesting, but basically say, here's a paper, and you'll go, oh, I want to read that, and boop, I'll be on to the next one. All right, another one, ChatGPT, using it throughout the clinical workflow, development and usability study. So this is great because we have to figure how are we going to evaluate these things? What does it mean to use these? So what they're really like is kind of like having an intern or a medical student or a nursing student, somebody who's knowledgeable, but maybe not experienced. And you want to quiz them about stuff and say, hey, this guy has this rash and this pain. What do you think he has? Oh, well, maybe he has Addison's disease. Oh, well, tell me about Addison's disease. Well, Addison's disease, blah, 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 and you have a conversation with them, right? So how does that work? It's not just answering questions on an exam, but actually going through the whole process. So they took these clinical cases that are used for education, and they're difficult cases, right? So they're not easy cases, but they also have a clear answer. And they developed a successive prompt process, which I'll show you. And they went through this differential diagnosis, diagnostic tests, and final diagnosis and management. So it looks like this. So the user reads in the history of present illness, review of symptoms, physical exam, and then says, which of the following cannot be excluded from the differential diagnosis? And then it says a bunch of diagnoses that cannot be excluded. And then this is a standard prompt. Then it says at which time of the following, which of the following are the most appropriate initial diagnostic studies? And then it recommends tests. So then they tell it the result of the test. Now, maybe it recommended a test they didn't have a result for, and they just say that test is pending. But if they have it, they'll tell it, and maybe, I'm not sure if they told it other things that it didn't ask for or not to get it up to speed. At the result of relevant diagnostic testing, at this time, which of the following is a correct diagnosis? And then it says, this is the right diagnosis. Then they say, okay, diagnosis of X is confirmed. At this time, what's the most appropriate management? And then it says what the appropriate management is. And again, if it was wrong, it says, okay, what's the treatment for the wrong diagnosis? Or they say, no, he had X, what's the treatment? Anyway, they had 3 users who went through these standard prompts, and then they assessed the answers. And they gave how correct it was, and then they took an average proportion correct that refers to all the replicates in all 4 different categories. And as you can see that, it ranged between 60 and 85%. It did poorly on pheochromocytoma, a woman who came in with a headache, and it did not do as well there, but did really well on testicular mass, testicular cancer. So that's kind of the range. And you can see they did better in diagnosis and less well in things like management and differential diagnosis. Clinical decision support. So these guys at Vanderbilt, they're so clever. They have a lot of free time on their hands, I think, to play with this stuff. So they have a decision support system. It's got alerts and reminders. There's logic in there, right? And so they go in and say, is this the right logic? Is our logic too inclusive, too restrictive? To say, this patient has XYZ, doc, you should not give them this drug, or you should do this test, or whatever it is. And that's part of actual clinical information systems today. So they wanted to see if ChatGPT could suggest changes to the logic. So they gave it the logic, and then it said, based on the information provided, it seems the current inclusion/exclusion criteria for the clinical decision support system alert are appropriate. However, it may be helpful to add additional exclusions. And then it goes on to list these things. Now, this in and of itself was clever, but you have to really, if you know that they also last year, or well, now 2022, I did this year in review, and I talked about a different paper they did called Clickbusters. And the purpose of Clickbusters was also to improve the logic of these rules, only it was done by a committee. And they had this whole committee, and it went through this whole cycle of different people going, okay, this is how you reduce the clicks, and this whole big process, and would take like 3 months to go, let's change the logic so that we can reduce the number of false positive alerts or increase the number of true positive alerts. And this thing, they just do it in, like a few seconds. They just type in the logic and say, what do I do? And it says, here's what you should do. So interesting, brave new world. Pharmacoinformatics. So blockchain frame-based framework to support pharmacogenetic data sharing, Alboe and Davies at University of Manchester. So if you know anything about blockchain, if you know a lot about blockchain, there's a lot of hype about it. It's a way of encrypting information in a linear way, and it controls who can unencrypt it because it uses public and private keys. And there's often people saying, we're going to use blockchain and it's going to save the world. And you go, you could just encrypt the file with anything and give it to the person who needs it, and they can unencrypt it. What's the blockchain thing? Oh, well, it's decentralized. Okay, great. So there are many points where it can be attacked, So there's a lot of hype. And one of the things, though, and they talk about it in electronic health records, is that it would give the patients the ability to control who sees which part of the record, because they can encrypt they can encrypt their record using private or public keys for particular providers, and then only those providers can decrypt that part of the record. And so, they looked at that. They developed a whole tool for doing this. I'm not going to go into all the design requirements. They go through a lot. It's a very nicely described process, but I included because it's got this dashboard. And the idea is a patient go into this dashboard and decide who gets to see which part of the record. Now, it looks pretty technical, but it does have tutorials and ways to walk people through it. Real question is, will a patient ever do that? Or will they just go, I don't know, doc, you can see my whole record. I don't care. I got nothing to hide. Or will they just, be overwhelmed by it and go, oh, nobody can see my record now because I'm not going to use this thing. So we don't know. But they at least put it out there so we can test this idea. Women in AMIA is a special working group. It's not a working group, it's a task force that helps, among other things, to promote professionalism of women in informatics and education. Women in informatics. Women are underrepresented in informatics, as they are in many technical fields, although AMIA is getting better. And still has a ways to go in terms of leadership. So they have a number of things that they do for career development, and they wanted to see what people thought of that. And they did it with a survey through the AMIA newsletter. They got 109 women, 65% in academia and research in various career stages. And they wanted to see if they thought that that women in AMIA supported women informaticians. They wanted to see about the AMIA events and leadership obstacles and work-life balance. So the top three needs, not surprising, networking opportunities, sort of cracking into the old girl network, or the old boy network, or the new girl network, or whatever it is, awareness of gender-specific challenges in career development, and improving gender representation in AMIA leadership. The last three presidents of AMIA have been women, so including the current one. So I think we're doing okay there. So they provided a bunch of pictures, but what I got some summaries of the data, and it was interesting that they thought how effective are these panel discussions, scientific sessions, scientific workshops, and social events. So each of these is a different event, and it looks like everything, ages 21 to 30 thought everything was pretty low effectiveness, but people 51 to 60 seemed like things were pretty high, and over 60 seemed to be pretty high. So it skews with age clearly. What was interesting though, that's the attendance. But then so this is the effectiveness. I'm sorry, that was attendance, but the young people thought it was effective even though they didn't go, and older people went, but they didn't think it was effective. And then they also looked at by career domain rather than age. And so academia, lots of people attended in academia, but again, it's skewed towards government in terms of thoughts of effect. So it was an interesting survey. I think what they didn't do is look at sort of where people were at their level of experience. Were these leaders? Were they new people? I mean, they have the age. That's sort of a proxy for that. All right.
I'm Jacqueline Yu, a clinical informatics fellow at Mass General Brigham. This year's honorable mention under Women in AMIA is a paper entitled "Accomplished Women Leaders in Informatics: Insights about Successful Careers"
online too.
by Payne et al. A thematic analysis of interviews with
Can you hear it
16 women
online?
informatics leaders.
Yes.
These include importance of role models in community, as well as gender-related challenges in leadership.
I'm sorry, what
positions.
she's talking.
I'm Jacqueline Yu, a
talk over
clinical
her,
informatics
which is
fellow at
unfortunate.
Mass General Brigham.
So is she looking
This
at
year's
accomplished
honorable
women leaders
mention
and
under
insights?
Women in AMIA is a paper
Talk
entitled
over.
"Accomplished
You're gonna
Women
hear this.
Leaders in
So looking at
Informatics:
coded
Insights
interviews.
about Successful Careers"
There's a line.
by Payne et al. A thematic analysis of interviews.
Let's try this again.
Interviews with 16 women informatics leaders. Theme.
This will probably just affect people at home.
I'm Jacqueline Yu, a clinical informatics fellow at Mass General Brigham. This year's honorable mention under Women in AMIA is a paper entitled "Accomplished Women Leaders in Informatics: Insights about Successful Careers"
This would
by
be
Payne et al. A thematic analysis of interviews with 16 women informatics leaders. Themes include
I'm not going to talk over her.
importance of role models in community, as well as gender-related challenges in leadership positions.
All right,
Captured
so
by a
they're
quote,
looking at
"We are
challenges
present
to
as females
leadership
in the field,
and
but
talking
definitely
about
still
how
a
women are
male-dominated
saying
field."
one of the
Other
points
themes
is
include
gender-related
fulfillment for
challenges,
meaningful impact
saying it's
and the need for
females are in the field, but
authenticity
it's
and
still a
resilience.
male-dominated field.
Captured by a quote, "We're trying
I'm
to
looking
address
at,
real problems. You're
fulfillment,
not done until you make the difference."
for making a difference. Leaders need authenticity and resilience. They say we're trying to address real problems. You're not done until you make a difference. So it's not just about advancing in the field, but actually making a difference. Second paper, and this is so this now a new topic, intensive care informatics. So there were three papers that they pulled up. They all use machine learning for different purposes. So it was interesting to compare and contrast the papers. One of them was looking at all-cause mortality, and these are interesting applications for machine learning because there's a lot of data. We don't always know the significance of the data. When somebody dies, it's pretty solid piece of data. We know that if they die in the hospital, we know, and we record that, and so we have an outcome that's a hard fast. We don't know if we discharge them, they die the next day. We don't know that, but at least people who at least make it to discharge or don't, hard and fast. And a lot of times we look at these people and we go, wow, we could see this coming, but we didn't recognize it. So even the humans are going, there was something that I knew he didn't look right 2 days ago. And we tried these things and it didn't work. And now it turned out we were on the wrong track. You really had this other problem. So there's clearly findings that are early on that if we had the right neural network or the right, model, we might be able to tell. And so these things did really well. And people do this a lot with, especially ICU, because there's this big outcome and there's a huge amount of data. What they did here in this first study was it was a prospective interventional study. So they used the system to predict whether somebody was going to die, and they changed their care. They decreased transfer time to the ICU, and they improved mortality. So that was huge. The second one I thought was interesting because they were looking at predicting whether somebody's creatinine clearance changed. That is, was their renal function going to change over time? And that's. Well, we care if they're going to die. We care if they're going to get sepsis. This is an interesting thing because it predicted how you were going to adjust their medication, right? So if you say this person's renal failure is going to start to deteriorate, and we won't know it until a day later because that's when the creatinine starts going up. It doesn't go up immediately because you got to start making creatinine that doesn't get excreted. But if we can predict that somebody's going to go into renal failure, we can adjust their medicine before that happens. So that was interesting. And then the last one was looking also at in-hospital mortality, but it was interesting because it was a multi-center international study as opposed to a single site. So those three papers have some contrast in the same area. Natural language processing, using ChatGPT on the US medical licensing exam. Okay, so a different exam, not an informatics exam, not diagnosing cases, but looking at medical education. And so they did the same thing. They took a bunch of test questions and they say that it did passing threshold for that test is about 60%. And the training, they did no specific training. They just used ChatGPT, and they made sure that the exam that they used was not somehow part of the training materials, right? Because it's whatever's in, open crawl and whatever other sources they use. So they made sure the exam wasn't in there because that would have, skewed things, right? And so they found that its insights, it had valid insights in almost 89%. And there was agreement between answers and explanations in almost 95%. So, did pretty well. Humans would be very challenged to do that well. Okay, student working group. So there's the student working group, which is where I drew the trainees from. Beyond mathematics, statistics, and programming, data science, machine learning, artificial intelligence competencies, and curricula for clinicians, informaticians, science journalists, and researchers. So teaching informatics to different groups. And so they looked at how they would teach, at various universities, so Oregon Health Sciences, WashU, and also Columbia, how they would teach, what would they teach to, for instance, a science journalist? So evidence and inference, which introduces basic methods from several different scientific disciplines. So they have all these different groups they're trying to explain informaticians to. Obviously, applied informaticians are going to need to know different things. Clinicians are going to want to know, well, how do I know this works and how do I use it? Whereas applied informaticians will be, how do I build a good one or how do I make it better? And then biomedical researchers and trainees will be using it in different contexts. So interesting to look at the compare and contrast there. Another student working group, honorable mention, mapping the delineation of practice to the AMIA foundational domains for applied health informatics. So the question is, do health informatics programs prepare students for real world? And so they looked at the concordance or the alignment between what's called the foundational domains of biomedical informatics training, which have been defined by AMIA, and there are 10 of those, and they're represented in these diagrams, and there's social and behavioral and health information science and technology, and there's overlap, right? So health information science, health and information science overlap in health information science and so on. In the center there, if you can't read it, says social, behavioral, and information science and technology applied to health. So that kind of brings all these things together. AMIA said we should be teaching people all of these things. Well, there's a lot of programs out there, and what do they do? How did they do with that? And it turned out when they looked at these different programs, and they counted up, okay, how many programs, talk about, for instance, social science, social and behavioral aspects of health, which is the little bar in the middle there. And then the gray is whether it was a topic, and blue is whether they do anything practical, whether they give them any exercise, whether they actually get to, use these in laboratory exercises and so on. And you can see that there was a lot of variability The big one there is health information, science, and technology. Not surprising. They do really well with that. But some of the others, despite the fact that AMIA and others say you should be teaching about these things, they're largely ignored in the formal programs. This one, consumer health informatics. It made me feel like I wasn't alone in the darkness, exploring dementia care, network communication, and coordination through a digital health platform. Anna Linda, Nicole Warner, University of Wisconsin-Madison, Indiana University. And what they did was they developed a communication platform, fairly simple, a straightforward platform, to allow communication among people who are taking care of people living with Alzheimer's disease and related dementias. And basically, one of the apps was a care journal that allowed people to write down what's going on with the patient so the next person could find out. And this included family members who were helping with caregiving. And so what they found was that, people were saying, this app was helpful because before a person came in for their shift, they could have advanced information, know how things were before. I'm caring for my mother-in-law right now at home, and every day we get a different aide. They can't seem to get an aide to come back. So we got to retrain this person every day, and it's exhausting. We could really use something like this. So, and she doesn't have Alzheimer's disease, but she's got a lot of other stuff going on. So it seems like it could be useful. Tracking information, mapping decline. So mapping decline, you go in and see somebody in a certain state. And a side story, I was covering a big practice in Columbia, 25 physicians. On a weekend, I went in to see a patient, and he was kind of out of it, he wasn't talking, he was kind of drowsy. And it said, dementia, stroke. And I thought, well, is this guy always like this? Because I'd never seen him. They didn't really, they said, oh, he's getting ready he had pneumonia, he's getting ready for transfer to the nursing home or something. And the nurses just said, well, we don't really know. And this is our first time seeing him. And so I kind of examined him. I didn't see anything cute going on. I went about my business. So the next day I come back and he's awake, eating breakfast and doing this Saturday New York Times crossword, which is the hardest of the crosswords. And clearly his dementia was pretty mild. His stroke wasn't prevented. So he was over medicated the day before, but I didn't know. I thought that was his standard state. So it happens to everybody. Okay. So this was from the title. Made me feel like I wasn't alone in the darkness. And this was somebody saying, I felt like the people coming in all know about my family member who they're helping. They're part of that team. So it's pretty touching to read the paper and see the full quotes out there. Out of all my brothers, probably 2, maybe 3 would actually hit the notification, go look at it. All right, so that's the application there. How am I doing on time? Okay, I'm doing all right. Nursing informatics, removing roadblocks to promoting health equity, finding the social determinants of health addressed in standardized nursing classifications. And that is in Jamia, Cheryl Wagner, Karen Lopez, University of Iowa. So looking at social determinants of health and disease, big topic right now. And how does the EHR do at capturing this information? And do we have coding terminology so we can capture this in a standard form, right? So we want to summarize, what's people's education level? How much do they smoke? How much do they live in a neighborhood that has access to fresh food? There's all these things we can talk about, but if we don't have ways to code them in a standard way, it gets really hard to summarize data. Even the NIH, which has these common data elements, 7 of the institutes have common data elements on smoking, and none of them use the same coding system for smoking. So one, NCI says, well, what do you smoke? And NHLBI says, well, how much do you smoke? And another one says, how long have you been smoking? So they ask all these different things, and there's no standard. So here they looked at the nursing classifications, which have been in use for 50 years. Nurses are way ahead of medicine in terms of things like coding clinical information. So there's NANDA, there's NOC, there's NIC. These are different terminologies, relatively small. They don't have every diagnosis in the world. They have the diagnoses that nurses deal with, right? So, inability to cope with, their diagnosis, need for education at home for home care. And some of them are for, family members, code them, the family member doesn't know something and they code that as a problem. Okay, so what they did, just to orient you to these, they looked at various social determinants, so economic stability, social community, education access, and then they looked at the different terms people would use. They had 9 in, for instance, economic stability, and then they wanted to see how well did each of these terminologies cover those 9? And so if there were 3 or more matches, you'd screen. If there was 1 or 2, there's yellow, and if none, it's red. So you can see, for instance, for economic stability, they did pretty well. Some of these are diagnoses, some of these are interventions, some are outcomes. So there's going to be, there may not be overlap between these. They're different domains. Social and community context, there was one there and that Nick didn't have. I should go look that up just to give an example of something it didn't have. And then some of the others, neighborhood and built environment, and healthcare access and quality, that was at 49 different things. And again, you see a lot of green and, some yellow, very little red. That's pretty good. These terminologies weren't created in response to the need for, they were already doing it. The nurses were way ahead of us. Okay. Biomedical imaging informatics, shortcuts causing bias in radiology, artificial intelligence, causes evaluation mitigation. Banerjee and Gichoya at Mayo Clinic and University of State, Arizona. They were looking at artificial intelligence models for medical imaging, and they were looking at the issue of shortcut learning. Okay, and shortcut learning is you find something in the image that helps you know something about the image that wasn't really intended. For instance, if you show somebody an X-ray and you say, okay, and they've done studies about this, is this person Caucasian, African American, Asian, and it turns out that X-rays visual or image analysis of chest X-rays can tell African American from Caucasian patients, and they don't know why. There's a paper we did previous year, where they blocked out different parts of the X-ray and they removed different things, and it still did it. So they don't know it wasn't body fat content or bone shape. They don't know because it was a neural network, so they don't really know what was doing it, but it could do it. But imagine you left the name of the patient on the X-ray, right? And then it would say, oh, I can figure out maybe from the name of the person, whether it's male or female, or maybe I can figure out something about their race, or, so that's a shortcut, right? It's not really there to help, that's not part of the challenge. My favorite one is predicting, mortality from a chest X-ray. How bad is the X-ray? Well, if there's a chest tube in there, that's pretty bad. Somebody has a chest tube, and if they have a chest tube and a pacemaker and a left ventricular assist device, you go, yeah, this patient looks like they're pretty sick, but it's based on, it's kind of cheating, right? So they were looking at those, and the important thing is that they looked at the various various types of bias and found ways to model the bias and infer when it was occurring, and then develop some methods for mitigating those biases and figure out how do you remove those kinds of things from the process.
In recognizing the importance of utilizing
okay.
In recognizing the importance of utilizing information systems to optimize delivery of care, we highlight the following paper entitled Association of Physician Burnout with Perceived EHR Work Stress and Potentially Actionable Factors, published in AMIA and led by Dr. Tyseal and co-authors at UC San Diego School of Medicine. Utilizing a mixed methods approach, the study sought to assess which EHR and non-EHR factors may be driving workload-related stress and burnout. Physicians from across multiple specialties were surveyed during the height of the COVID-19 pandemic and asked for
medical specialty.
Overall,
And they found out that,
participating
not
physicians
surprisingly,
reported experiencing burnout.
physicians
The authors
had,
found that indeed both EHR and
overall had a very
non-EHR
high
factors contributed
stress
to an
level,
increased
risk for
association with
burnout,
burnout symptoms.
and that there
Given
was
the
both
variation
EHR
in
and
perceptions and
non-EHR
workflow
factors
processes
associated
across
with
different
burnout.
health
This is
systems
often,
and
we often blame
subspecialties,
the EHR,
findings
and it's part
demonstrated
of
a
the
need to
problem,
better
but there's
understand
others as
targets
well.
for alleviating burnout.
So
Identifying
they
support
made
strategies will not only
recommendations about how to
strengthen
better
provider
support
resiliency during
physicians'
public health-related
resiliency
stresses,
in
but
light
also
of
in the face of anticipated
challenges.
challenges
For
due to
instance, that
aging
our
populations
populations
and
are aging,
staffing
so they
shortages.
become more difficult to care for. So, all right, dental informatics. So this was there was the only one paper from the dental informatics group this year, which was unusual because they have really good records, electronic health records or electronic dental records. So they do a lot of interesting things with those. But in this case, it was just one paper, and they developed machine learning algorithms to predict who was going to need dental implants. And they had six factors that they looked at, and different models used different factors. Oops, and they just had a high accuracy. So why do this? Well, because you can figure out who's at risk and who you can do more preventative measures with, or encourage to do preventive measures. All right, global health informatics. So this was a paper that looked at integrating real-world data from Brazil and Pakistan into the OMOP common data model. So OMOP is acronym, blank going right out of my head.
Observational model for outcomes in something.
Observational model, outcomes, what's that?
Outcomes for partnership.
Oh, observational models for outcomes partnership. So it's a data model for sharing data from electronic health records. So it's a way to represent, say, problem list medications, laboratory results, vital signs, that kind of thing. Very simple, straightforward files, very easy to generate, and then relatively easy to integrate if you can get the terminology coding right. So they looked at, they were looking at COVID patients in Pakistan and Brazil. So two very different countries, differently, different kinds of resources, very different, population risks, and that they are able to look and be able to predict who has more serious outcomes. Men, elderly, pre-existing health conditions. Not a big surprise. What's interesting about this paper isn't the medical stuff; it's the technology. The fact that they were able to use this OMOP model and the Open Health Data Sharing Initiative, I think it's called Odyssey, for sharing. So it was a real success for them. And these are low resource settings, and they were still able to generate all this data. Okay, AMIA 25x5. So this AMIA 25x5 is a task force which has taken on the challenge of reducing medical documentation to 25% of its current level within 5 years. They've been doing it now for probably 2 years. And it's, the initial work is just figuring out how do we measure the burden of documentation? How do we measure excessive burden? And so we have a paper coming out. Did it get accepted? No, we just submitted it to AMIA, in which we try to define some of these things and talk about how to measure them. So yes, documentation, and for those not familiar, documentation means writing notes in a chart, writing orders and saying all the things that you need to say in the order about why you're doing, justifying it. So it's putting in writing what you're thinking, documenting or what you've observed, what you think's going on, what happened to the patient, all of that stuff. We have to record an electronic health record so we can take care of that patient, so we can use it for research, so we can use it for decision support and so on. It's burdensome. It's a lot of work. And there was a paper a few years ago by Chris Longhurst and others where they showed that in the US, part of it is our notes are like 10 to 20 times longer than the notes in Europe. So our burden of just creating notes is terrific. We create shortcuts for doing that, like allowing people to copy and paste from a previous note, and that saves time. But the problem then is people don't update the note. So you'll read the note and it says, oh, on Tuesday they were post-op day 3, and on Wednesday they were post-op day 3, and on Thursday they were post-op day. And you're like, well, how many days post-op are they? And people have problems on their list that were long ago resolved, but people just keep copying them over. So trying to figure out how do we reduce that documentation burden, either by finding better ways to do it or saying these are things we don't need to document, or we find other ways to do it. So the first step is trying to measure the burden and characterize it so we can then figure out what to do about it. So in this case, they're looking at the duplicate information in the record. So this is this copy and paste. They looked at notes, 100 million notes on 2 million patients. They use a 10-gram, 10 word sliding window, over 32 trillion words in all these documents. 50% were duplicated in the record. 54% were the same author copying over his or her previous work, and 46%, the remaining was a different author. So people were copying other people's words and then saying, yeah, he said it yesterday, so I'm going to say it today. And this has actually somewhat gotten worse over time, from 2016 up to 2020, which was the course of this study. And you can see different places. Inpatient history and physical was less duplicated, but you look at inpatient progress notes, and it's, because it's the same thing every day, right? You go in, the patient's, yeah, I still have this, doc, and we're waiting for this. And, okay, you're on day 4 of this antibiotic, and tomorrow you'll be on day 5. That stuff, it is very repetitious. And so we see that it's not necessarily bad. Okay, it's not necessarily bad, but it's potentially bad if people are copying things and as a shortcut and not modifying, not reviewing it. They're signing their name to something that's not true. Then it's bad. All right, people and organizational issues. Articulation of post-surgical patient discharges, coordinating care transitions from hospital to home. They were looking at general observations, patient shadowing, chart review, clinician interview, and then follow-up phone interviews for patient cares. What they were trying to look at is how are the members of the care team coordinated between inpatient and outpatient, so that when the patient goes home, the right things happen. They come in and get their wound checked on the right day. They come back and get their sutures or their staples removed at the right time. If something goes wrong, somebody at home knows what to expect and knows what to do. So they characterize this, and I don't have time. They have nice graphics for all these things. I don't have time to go into all of them, but the important thing is they actually characterize this, because normally we just go, okay, go home, come back tomorrow. And then the patient goes home and they say, what'd they say? I don't know, I'm supposed to go back, but I forget when, or, there's not it's not formalized. And so here they were actually characterizing all these steps, because once you do that, then you can build systems that help you do it, right? And you can figure out where things falling through the cracks. In the medical clinic, patients come in and say, so do you ever when did you get like X done? You were supposed to go to rehab, or you're supposed to go to the dermatology. And they say, oh, they never called me for a visit. So now it's 5 months later and you're, well, we got to send you back to dermatology. That thing on your skin's getting worse, or whatever it is. And people fall through the cracks, whether because they didn't answer their phone, or because whoever's, didn't call them for an appointment, whatever the reason is. Once we characterize that process, we can get a better handle. So as an informatician, clinically, there's a lot of interesting stuff there, but as an informatician, it really appeals to me, because finally paying attention to this process. And what they also found was that when people don't have systems to help them do things, or the system's owners, the clinicians are taking end runs, shortcuts, doing back channel things to make sure things happen. So yeah, I wrote this order, but here, I'm going to write this down, take this home, give this to your wife, and then she'll help you, get the right appointment, or whatever it is. Okay. Okay, framework to identify ethical concerns with machine learning guided care workflows, a case study of mortality prediction to guide advanced care planning. Dana Caliero, Danton Chard, University of Toronto. And so what they're looking at here, machine learning guided AI, are there ethical concerns there? There may be, because one of the problems is that these things can make recommendations and we don't understand the basis. They look very authoritative, but we don't always understand how they came to their conclusion. And then we, physicians, nurses, patients, we have to accept those or reject them and suffer the consequences. And so they were looking at people's ethical concerns, and the concerns of the healthcare designers, the administrators, clinicians, patients were all different. And they got different views on these things, and they proposed this value collision approach. So people have different values about a certain aspect of machine learning system, what it's supposed to accomplish. And the designers think one thing and the users think another, and there's a collision. And so they have this very nice diagram to diagram this, and I won't go into detail, but I'll give you an example. So transparency and evaluation of efficacy. So we want to make sure the thing works, but we also want to know what it's doing, right? So transparency is understanding how it works. Evaluation of efficacy is seeing how well it does that. You don't necessarily have to know how it works to see if it's working well, right? So the designer says, I don't think doctors are going to understand how a model really works. I think to be able to look back and say, these patients we screened last year and this is what happened to them, to see the validation. So the designer doesn't care about transparency and really just wants efficacy. The clinician says, I want to know what factors it takes into account and a little bit about how they're weighted. I want to know something about performance of the algorithm. So these are people's opinions about how they want to interact with these. And so having that framework then provides a way for actually addressing those issues, so that the designers can know, for instance, what the clinicians or the patient's concerns are in the process. Okay. We're going to have the same problem. I wish there was a way to amplify this sound. You could all log into Zoom.
Is the problem that you don't hear that sound in that room? Because we hear both very, very clearly. Actually, they're fighting with each other. So I don't know what happens in the room there.
Well, I can tell you what happened is don't say anything else until I lower the volume on the, I turned up the volume on Zoom, and you were very loud. So I guess your volume's good. I have a volume control at the podium, but it doesn't seem to be affecting it. This thing, does this have a volume control on it? This little L that we're using here. Because the sound is coming out of here. So let me take a chance. Let me do this. There we go. let's see if that's gonna do it. And if it does, we can go back to those other things. Okay. All right. I brought this up because there's a nice video coming up. How are we doing on time? Good. All right, so a vision transformer for decoding surgeon activities from surgical videos. So surgeons, I've been in biomedical informatics for 43 years, okay? And I can tell you that for most of those 43 years, the surgeons were not there. They're like, we don't care about informatics. We're busy saving lives over here, also making lots of money. You guys are, working with computers. That's all well and good, but we're doing real stuff over here. My brother, a brilliant plastic surgeon, hates computers. He asked me the other day what a scroll bar was. So, not a computer guy. But lately, the surgeons have been doing some amazing stuff. And so this vision transformer, decoding surgeon activity, they take videos of people performing surgery, and then the system analyzes it and tells them how they're doing. Okay, so Kiyase and Hung at Cedars-Sinai in Los Angeles. So they decode interoperative surgical activity from a video. They have a taxonomy of surgical skill for things like tissue dissection, surgery substeps, and then it assesses this and it looks for discrete surgical gestures, and then it can show outliers in the surgical behavior, and it provides visual explanation for the skill assessment. So it's pretty cool. So I'm going to show you this, and if you're squeamish, don't watch, because it's basically what it's going to do is the surgeon is using a robotic surgery to connect up an intestine. All right, they cut out a tumor, and now you got two tubes, and you got to sew them together. So let's see if we can fire this up here.
Based on SICE's capabilities, we can offer the following feedback for this video sample. For this stitch, your needle driving was executed poorly due to activity between the 2nd and 5th second, where we identify what is happening, how well it is happening, and why that assessment was made.
Okay, so that's just done from looking at the video.
Based on SICE's capabilities, we can offer.
And they trained it on other videos that were assessed, and it's just amazing. So here's another one: autonomous robotic laparoscopic surgery for intestinal anastomosis. So different group, same problem. How do you sew together two ends of a cut intestine? Only here the robot's doing it. Okay. And so, and it's doing it because it learned from things like the previous system. So semi-autonomous. So humans go in there and help. They clean out the area. So the human's like this, the surgeon's like the scut, just goes in. Oh, get that out of there. Suction, or suction, damn it. So it must be interesting to be the surgeon in that situation. So semi-autonomous suturing robot, STAR, to do this minimally invasive things that otherwise would be pretty invasive. And it uses convolutional neural networks to track tissue motion, account for breathing artifacts. So because people are breathing, the thing's moving, it's their intestines. The intestines themselves move. So it's a pretty challenging environment for a computer to deal with. They were slower than humans compared to, but on the other hand, at some point you might be able to do things like this where you don't have a human at all, or a minimally trained human. Let's see, is this going to start up on its own? No, I have to start it.
In this video, we highlight the Smart Tissue Autonomous Robot, also known as STAR. STAR is a transformative surgical robot for autonomous soft tissue surgery. The system consists of two lightweight robotic arms, a robotic suturing tool, a novel 3D endoscopic camera, and a surgical workstation to monitor the procedure. STAR's suturing arm has 7 degrees of freedom and redundant force sensing that enables a wide range of motions with safe operation. Additionally, STAR has a gravity compensation mode so that an assistant can bring the suturing arm into the surgical field and align the tool for the procedure. Anastomosis is performed under laparoscopic constraints where the tool motion is restricted to pass through a single point on the patient's body. For ex vivo tests, STAR sutures synthetic tissues placed on a linear stage to simulate breathing artifacts. Tissues are also subjected to random deformations, similar to pre-clinical conditions. For in vivo applications, a surgeon applies 3 transabdominal stay sutures to stage the bowel. Near-infrared markers are placed on the corners of the tissue so that deformations and breathing artifacts are tracked in real time. These markers remain visible despite unexpected blood and tissue occlusions. Using the position of these markers, STAR generates 3-dimensional point clouds of the surgical site and overlays optimized surgical plans for the anastomosis. As shown on this tissue, when a surgical plan is not consistent with a three-dimensional point cloud, the surgeon can initiate a replanning algorithm to generate a new plan. STAR creates an anastomosis by applying a running suture along the back wall of the small bowel. A human assistant removes all loose thread from the surgical field to prevent the formation of locking sutures. STAR completes the second half of the anastomosis by using a running stitch to close the front wall. Sutures are applied with uniform spacing as determined by the surgical plan. At the end of the surgery, the anastomosis is manually inspected for missed stitches and defects. Here we highlight a representative anastomosis as performed by the STAR surgical robot. In this video,
public health. So public health, lots of public health papers. I told the working group to give me 4 papers. They gave me 6 to choose from. And there was enough overlap that I included all 6. So there were 4 on surveillance. So looking at disease surveillance and immunization systems, electronic case reporting for COVID-19, representation of disaster hazard with SNOMED CT, which is a terminology for medicine, and then leveraging electronic health records for chronic disease surveillance, EHR-based network and disease surveillance. So lots of different places, a couple in Minnesota, Australia, CDC. And then there was also exposure notifications. We had some experience with here in Alabama, beginning of COVID. So epidemiologic impacts of NHS COVID-19 in England and Wales, and looking at trying to figure out who, telling people, hey, that person you were with yesterday, they came down with COVID. And then looking at trading off privacy and utility. The Washington State experience with a similar type of application. So I just have kind of a summary of the data that they used, the papers to see the doing. As might be expected, there were often things that they did well, but it didn't do as well as we. Turns out actually contact tracing is a very different problem because a lot of times it's just not, you don't know who you're in contact with.
Hi everyone, my name is Ivani Patel and I'm a PGY1 at the University of Pennsylvania and part of the Primary Care Working Group as their first trainee. The paper we chose to present by Shi and al. Is about the implementation of a clinical decision support system for the management of chronic conditions including diabetes, hypertension, and hyperlipidemia. The study compared the effectiveness of implementing a team-based strategy to tackle these chronic conditions, either with or without the concurrent use of a CDSS. Across 38 community health centers in China, each group of 19 centers was given the opportunity to provide public healthcare services to patients who had uncontrolled diabetes, elevated LDL levels, and elevated systolic blood pressures. The interventional group used the CDSS to guide clinical decision-making, using information like how many prescriptions were dispensed, appropriate dosage levels of medications based on patients' lab results, and personalized lifestyle and training regimens based on patients' recorded activity levels. The results noted a significant but modest decrease in primary outcomes of controlled HbA1c levels, systolic blood pressures, and LDL-C levels in the group that had implemented the CDSS. Next slide. While this effect was modest, as evidenced by the slide, the study went on to highlight the potential impact of incorporating CDSS in settings that have a high volume of healthcare, especially in primary care settings. In many low and middle income countries, the ratio of doctors for every 1,000 patients is anywhere from 0.3 to 1.6, whereas in high income countries, this ratio actually jumps to 2.6. Given the increasing burdens of primary care practitioners in LMICs, this study highlights the potential of reducing this physician workload, improving evidence-based medicine by using up-to-date guidelines about chronic conditions, and potentially reducing the administrative task load by systematizing decisions that would otherwise be made manually. Next slide. Our honorable mention paper by Rodenstein et al. Goes hand in hand with our primary paper. This study quantified the amount of time that was spent by each medicine subspecialty taking different types of notes. For example, after-hours electronic health record manual data entry versus using Epic smart phrases versus using dictation tools. What the paper found was that smart tools and data entry were the most used types of note-taking across all subspecialties in medicine, and that dictation tools were the least used mode. It also showed that the manual data entry and smart phrases took the most time for many of these doctors, whereas the dictation tools used the least amount of time. This highlights the discrepancy in note-taking efficiency in the medical workplace and potentially leads us towards a future where early medical trainees like myself are trained on more efficient note-taking strategies than those we are currently trained on.
Okay. Lots of nice graphics in that paper. I think we are kind of running out of time. I'll just touch very briefly on the last few papers. This was a paper using AI to detect when a bot was filling out a survey. So they put, you do a study, public health study, we have an online survey, and bots sometimes fill these things out. And so they wanted to look at ways to do that. And so they, I don't have the diagram, but they were able to predict pretty well. Occasionally they would, they'd have false positives, throw out real survey results, but mostly pretty good. And it occurred with a striking frequency. Informatics maturity is a new working group. And it's not about the informatics of old people. It's about the maturity of informatics systems. And so it looks, trying to characterize systems about how do they do data aggregation, data transformation, secure storage, access to research, and so on. So things that we do, and some of them we do well and been doing for a long time, and some of them we're just kind of dabbling in and don't have mature systems. So it looks at things like how you maintain it and so on. Diversity, equity, and inclusion is an access is a new task force in AMIA, and got a broad charge. This particular study was looking at how racism in electronic health records is defined so that we can then characterize information in the record and learn how to collect data that will be more useful for helping with this public health crisis. So it differentiates between structural, individual, and institutional racism. It provides some definitions. Okay, so I'm down at the end here, just to give you a sense of the scope of this, all of the 23 to 24 working groups, 3 committees, 113 papers. I presented 37 of them today, but I did 42 back in November, and some of the new areas that we covered. These are the journals. Some of them, just one paper in some of these, but so Jamie well represented JBI as what we expected. I've been tracking since 2020 how often papers dealt with COVID-19, and it started dropping down. So we're down, maybe we're down to 6 out of 6%, as opposed to 13% in the past. And then looking at the, how do these different working groups overlap with general topics like large language models. So NLP was a big one. Other AI techniques, lots of them actually, surprising, probably because large language models weren't generally available at the time. A lot of the papers, a lot of the research was done that was then published in 2023. Standards and COVID-19, of course, big topic. And then blockchain, in the past, that was a much more popular topic. So overall, there's kind of where this goes. You can get these slides and look at them in more detail. And so this is this is my room in New Orleans as I work feverishly on these slides. Those are the papers, and I won't try to go through all the credits, the authors, papers. It's all in here, and I have as I said, I have a link at the end. Getting there. There we go. There's all the papers. There's that QR code is for the AMIA paper, the AMIA version of the paper. Here's my group. And they're all identified again, the QR code for the AMIA version. It was terrific. They did a great job. It was a lot of fun. And then just to let you know a few things coming up. So next week, Tappan Maida is coming and is going to be here to talk about, it's not coming, he's here at UAB, is going to talk about quintuple aim in primary care, role of informatics and AI. So that's going to be exciting. And so you register and join. These slides, this current subset is here and it's got all the links in it. That's the link for the PowerTalks in general. I encourage you to come. And then on the 29th, we're going to have sort of the grand opening of the Department of Biomedical Informatics, 9:30 a.m. over the Hilton. And we'll have some refreshments. Dr. Agarwal will be there to sort of open the ceremonies, and we'll be talking about the Institute. A lot of you are in the Institute, and hopefully you're going to be there because you'll get to hear about what we're doing, what you're doing. And there will be a closed session for the department folks afterwards, but again, everybody there. And then opportunities. So recruiting faculty, I don't know how many people, looks like we got 38 people, probably 35 people online. We're recruiting and we don't have the job posting out yet, but we will soon. So just contact me or go to our informatics page and we'll have it posted there. That brings us, I think, to 11:01. So thanks for your attention. I'm happy to stick around and answer questions. Let me go off the sharing. Maybe I'll leave the sharing on, but look at the chat. Oh, people just commented on how well they could hear it. All right, so if anybody has questions here, or I can try to answer them, or thanks for your attendance. This is great. We're going to try to do these as hybrid from now on. Now the pandemic's over and get people back here in person. Some of them maybe we'll have remote speakers and maybe they'll just be remote. I haven't figured that out yet, but I think I like, even if the speaker's remote, getting us in a room together, I think is a healthy thing to do and for interactions. This talk goes so fast, it's hard to sort of latch on to things to ask about, but others will be more in depth and hopefully foster more discussion. So thank you. Anybody online have anything they want to ask? So there's a chat. Great work. Thank you. All right. Well, with that, Amy, you could shut down the recording and that'll be available online.
Yep. Thanks, everyone. And let me